There is no surprise in this case. This is a known case of carcinoid heart. My point in presenting this case is this is a very rare anomaly which we get to see as echocardiographers. To say how rare this anomaly is, the presence of neuroendocrine tumors, the incidence is about 2.5 to 5 cases per 100,000 people. And out of those neuroendocrine tumors, 30 to 40% of them have carcinoid syndrome, and 20 to 50% of carcinoid syndromes present as carcinoid heart or carcinoid heart disease. This case was referred to me from the Datta Medical Center, which is a well-known cancer hospital in Kolkata. It was a known case of ileal well-differentiated malignant neuroendocrine tumor with multiple metastases and suspected carcinoid heart. And the patient came to me for echo and ECG before a planned embolization of a liver metastasis. The patient was also hypertensive and was on telmisartan, aspirin, Beltam, and injection somatostatin once every 4 weeks, and a diuretic. He was a 162 centimeter tall man with weighing 57 kilos and a body surface area of 1.6 per meter square. The pulse rate was normal. The respiration was 22 per minute. It was afebrile. There was a red flush on his face and chest. There was edema both feet and pubis. Small enlargement of the breast. Enlarged nodular liver. Systolic murmur in the left sternal edge. I had got the case with the entire walk-up done for the carcinoid syndrome. And the CECT showed multiple hepatic lesions with small enhancing lesions in the terminal ileum and mild ascites. The PET scan was done. It had a terminal ileal lesion with metastasis in liver, mesenteric lymph nodes, left adrenal, and solid cystic nodular lesion in the lower pole of the right lobe of thyroid. Focal skeletal lesion involving 7 cervical and 6 dorsal vertebra. The gallium rotor scan also shows increased activity of the tumor. Urinary hydroxyindole acetic acid level was high, about 50, where the normal being 2 to 8 for that lab. The blood picture shows a hemoglobin of 10.8, creatinine was normal, and 5 hydroxyindole acetic acid level in the blood was also raised. I'm very sorry I don't have the NT-proBNP level because it was not worked up that way. And since I worked in a diagnostic center, I didn't have any scope to work it up that way. The serum chromatogranin, which is a marker of carcinoid syndrome, was severely raised. This was the ECG, which doesn't contribute much. I didn't get the chest X-ray of the patient. This is the first image of the echocardiogram, the standard parasternal long axis view, which shows nothing significant except maybe slight dilatation of the right ventricular outflow tract. This is the parasternal short axis view showing good contractility of the left ventricle, as has been evidenced in the standard M-mode picture, which shows a normal LV function with maybe slight thickening of the septum and enlargement of the right ventricle. The mitral inflow pattern didn't contribute much. It was a normal diastolic filling pattern. This is the short axis of the aortic valve level. You can see that the tricuspid valve appears thickened. And it was a normal tricuspid aortic valve with nothing more to add. This was the short axis at the basal level. I would skip that and let's go to the next picture. This is very interesting. This is the color flow pattern of the pulmonary artery. Now, if you observe very carefully, you can see a relatively high colored flow in the pulmonary artery in systole, whereas there is still a low velocity flow across the pulmonary valve in diastole. You can see this blue color flow in the diastole. Now, this is very interesting because this is something we do not usually get to see. This is because the RV pressure was so high, even in diastole, that the pulmonary valve was kept open. This is the pulse wave Doppler spectrum at the pulmonary valve. Sorry, continuous wave Doppler spectrum at the pulmonary valve. Here you can see, as I'm pointing with the arrow, this is the diastolic flow across the pulmonary valve, which I was talking about in the last slide. This is apical four-chamber view, which shows a dilated right ventricle and the right atrium. And have a look at the tricuspid valve, which we will see better in the moving pictures. You can see the tricuspid valve leaflets are thickened, shorted, and somewhat retracted. This shows the dimensions of the enlarged right atrium. Now, this is what I was talking about, the typical picture of a tricuspid valve in a carcinoid heart. The tricuspid valve leaflets, as I said, are thickened, fibrous, shortened. The cordia is shortened, so the tricuspid valve doesn't coapt properly, and there is usually a very free-flowing TR with them. The color flow across the tricuspid valve, the leaflets you see, they're just not closing, and there is a free-flowing severe TR. And the TR in carcinoid syndrome has a typical spectral pattern, which is evidenced here. It is a dagger-shaped pattern, what we call. There is a very early rise of pressure and with rapid decline. And the velocity is not very high because the valve is open and it's a very free-flowing, low-velocity TR. But this pattern is very classical of carcinoid heart. This is another picture of the same TR spectrum. This is a picture at the subcostal level, and the color spectrum at this level shows that we cannot see any patent foramen navel. Presence of patent foramen navel is very important. I will discuss that later in the part of my discussion section. This also shows a free-flowing TR. The inferior vena cava was dilated. I'm sorry, this is not a moving picture. It was dilated and somewhat non-collapsing. Now, the clinical features of a carcinoid heart disease include dyspnea, fatigue, a systolic murmur at the sternal border because of the TR, elevated JVP with a prominent V, ascites, peripheral edema, and pleural effusion, perhaps due to cardiac pulmonary cause or hepatic nutritional or a combination of these. The proposed algorithm for workup of a carcinoid syndrome metastatic serotonin-producing neuroendocrine tumor is there should be a 6-monthly clinical assessment and measurement of NT-proBNP at 6-monthly level. If the NT-proBNP level is less than 260 nanograms per milliliter, then the patient goes back to that 6-monthly follow-up state. But if the NT-proBNP exceeds 260 and the clinical features, or there are clinical features suggestive of carcinoid heart, a transthoracic echo is advised with a contrast study to look for carcinoid heart and patent foramen navel. If the carcinoid heart disease is confirmed, it's referred. If there is no carcinoid heart disease, but other pathologies are present in echocardiography, they should also be treated by a cardiologist. And the normal echocardiogram, if there's an echocardiogram is normal, then he goes back to the 6-monthly follow-up stage. These are the classic echocardiography features of a carcinoid heart disease. The tricuspid valve is usually thickened, thickened of leaflets and the subvalvular apparatus, diminished normal concave curvature of the leaflet, altered dynamic motion of the leaflets during diastole, fused and shortened chordae, retraction and reduced excursion of the tricuspid valve, and tricuspid regurgitation ranging from mild to severe. Pulmonary valve is also diffusely thickened. There is straightening of the cusp like the tricuspid valve, which of course was not seen in this case. This is a fixed, retracted and thickened cusp, and the pulmonary regurgitation and or stenosis. Left-sided carcinoid is rare. Why rare? I'll come to that later. The aortic valve and the mitral valve may also show diffuse thickening with thickening of the papillary muscles of the mitral valve and restricted leaflet mobility. Right atrium is dilated, so is the inferior vena cava. Right ventricle is dilated with reduced systolic function. And if there is metastasis, the cardiac metastasis, they may show up. Now, these are the key points about the carcinoid heart disease. Carcinoid tumors are rare endocrine malignancies, mostly arising within the GI tract, particularly in the terminal ileum and the appendix. It's characterized clinically by cutaneous flushing, secretory diarrhea, and bronchospasm. Occurs secondary to the paraneoplastic effect of the vasoactive tumor producing serotonin, and only occurs in presence of metastatic spread. The raised main mean urine 24-hour urine HIA level, which is an end product of serotonin metabolism, is a key diagnostic finding. Carcinoid heart disease, I have already told about the incidence, but its presence usually heralds a worsening prognosis. The vast majority of patients with carcinoid heart develop right heart failure caused by severe dysfunction of the tricuspid and pulmonary valve. Calcification of the affected valves is rare and may be considered a negative echocardiographic predictor of carcinoid heart. Preferential right heart involvement is most likely due to activation of the vasoactive substances by the lung. Left heart disease is uncommon and is seen only 5 to 10% of the cases, and it can only be present if there is an extensive liver metastasis and bronchial carcinoma, if there is a bronchial carcinoma, and if there is a patent foramen ovale. This is the importance of looking for a patent foramen ovale in a case of suspected carcinoid heart. And palliation of the symptoms and treatment and maybe valve surgery in selected patients with carcinoid syndrome may prolong the survival. This was a very important paper which I fished out from the net. This is an expert statement on the endocrine tumor. It was published in JACC in 2017. This is from where I got all my material, theoretical material. Thank you very much for your attention.